As we've already heard, we are seeing an alarming increase in the prevalence of diabetic retinopathy. Without a doubt, diabetes is taking a significant toll on the public health of this country. Dr. Ann Albright is with us to talk more about diabetes' impact on the eye, as we sort of heard a little bit earlier today. Dr. Albright is the director of the Division of Diabetes Translation at the CDC, and as such leads a team of more than 100 who strive to eliminate the preventable burden of diabetes through leadership, research, programs, and policies that translate science into practice. I'd like to welcome Dr. Albright.
Thanks. How y'all doing? Still with us from the cleanup batter. I'll use the baseball analogy here. I'm going to, first and foremost, I want to thank the organizers of the summit for the invitation and for including CDC. Vision health is critical to us. And you are hearing about it on behalf of the Diabetes Division because the Vision Health Initiative does reside in the Diabetes Division, as does the chronic kidney disease. And the leader of the Vision Health Initiative is Dr. Janan Sedin, who is here with you, and certainly John is on our team. So really want to acknowledge them and thank them. I'm going to start out with a little bit of audience participation here. I'm going to ask you to put your hand up, and once you put it up, you got to leave it up, okay? How many of you personally or have a first-degree relative with diabetes? So hands up. Okay, just look around the room as I ask each question. Again, leave your hands up. How many of you have a neighbor, family friend, somebody that goes to your church that has diabetes? Okay, do we even have anybody? Okay, if nobody had their hand up yet, I'd say, and how many of you are taxpayers? Okay, I want you to appreciate that because I hope this is a very real way to make this real to you. You've heard a lot of numbers. CDC is responsible for the nation's surveillance system, but these are your family. These are your neighbors, these are your children, these are your grandparents, these are your parents. So this is very much the reality of what it means for today to be 26 million people who have diabetes. About a quarter of those do not know they have it. So we're better in the numbers as far as who don't know they have it, but we still have a significant number who don't know. But look at the bottom of this slide, 79 million with a condition we refer to now as prediabetes. Means their blood sugar is higher than it should be, not high enough yet to have diabetes. Does anybody think of the Titanic when they see this picture? So if you think we have an issue with diabetes now, you ain't seen nothing yet. And I really want people to understand we're not trying to yell fire in a crowded theater just because we're trying to be alarmists. But it really should hit home to us that no one will be able to say, we had no idea. We had no idea that these issues were coming upon us, that the problem of diabetes, because it's the #1 cause of blindness, because it's the #1 cause of kidney failure, it's the #1 cause of non-traumatic lower limb amputation, and it's a huge contributor to heart attack and stroke, the #1 killer and third killer in the country. So diabetes is nothing to mess around with, and it is something that really, again, I hope you'll realize, maybe you don't have it personally today, but clearly by what we surveyed in the room here, you all know someone and someone pretty close to you. So I hope, and please hold me accountable for this, I want you to leave this session with either some new piece of information about diabetes or a new realization that you'll take back to your places of work, to your community, to your personal life that will help make diabetes a reality for you. And its connection certainly to vision issues, which is the priority for all of you. And how do we get that integration? How do we get that ability for other chronic diseases to be responsible for helping take some of the share of vision issues in the country? Because goodness knows, diabetes has got a big share of that burden. These are data that I wanted to also just briefly share with you. Again, you'll see the map getting darker and darker. In case you missed that, let me do that again for you. You can see over time what's happening with the prevalence of diabetes in the country. And I do want to emphasize, let's see, there's supposed to be a little pointer here. Let's see if I can find it. There we go. You'll notice that we've got this really quite major dark area in the country here. We now refer to this as the diabetes belt. So what else is that the belt of? Stroke belt, This is a really hard-hit part of the country. It doesn't mean that there aren't other parts of the country that are also certainly hard-hit. You can look in the Southwest, a lot of Indian tribal areas, Indian country. So this, I hope, gives you, again, a visual, a sense of the burden. This is prevalence, so that's total number of people who have diabetes. I'm going to give you some future numbers in a moment. But this was really to give you a sense of what the nation looks like as far as hard-hit areas and what we are facing as far as prevalence goes. So, like CDC, we don't have a crystal ball, but we do have brilliant mathematicians and epidemiologists who do modeling for us that allow us to take a look at what the future holds. You've heard some 2050 data around vision health. Here's the 2050 data for diabetes. As many as 1 in 3, it'll be closer to 1 in 2 for ethnic minorities, so 1, 2, 3, 1, 2, 3, 1, 2, 3, 1 out of 3. It's currently 1 out of 10. So it's, again, as we think we have an issue with diabetes now, it's going to get worse if things stay on the trajectory that we're on. And I think that's really the good news for all of us. It does not have to stay on the trajectory that it's on. In fact, it can't stay on the trajectory that it's on. This is unsustainable. This is unsustainable. Our healthcare system will not be able to sustain this kind of growth in diabetes because of those health issues, those comorbid conditions that I mentioned. So it really is imperative that if you're looking at sort of dropping the rock in the pond, that diabetes really can serve as that rock in the pond and the ripples that emanate from diabetes. Doesn't mean that there aren't other critical chronic diseases. We've heard earlier comments made that they share a lot of those risk factors in common. But there is an issue where we've all got to make some decisions about how do we focus, and then how do we also step back and look at the big picture and integrate and try to be as efficient as we can while we're still trying to achieve outcomes on behalf of heart disease and stroke, cancer, diabetes, obesity, those issues that are all very interconnected with each other. So hopefully these first comments gave you a sense of where the picture is now, where the picture will be in the future if we don't change, and I hope that's given you some sense of urgency and the importance of us really being able to tackle diabetes and these other chronic diseases. Why? For you, it's mostly important because of vision-related issues, but again, because of your family, your friends, your neighbors, and likely yourself in the future. A colleague of ours at CDC wrote a book. She's very much involved in health disparities work, and I love this quote because I think it says a lot. For those of us who are personally impacted by diabetes, and I hope you'll think about these words, diabetes can be fairly described as a whole life disease, in that few areas of one's life is not either influenced by or implicated in the manifestation and control of the disease. Diabetes does impact all of you. It impacts all the organs we've listed, and it certainly impacts a lot of the things you have to deal with as you're making decisions, things that most people get to take for granted. What am I going to eat today? How much stress is in my life? What do I have to do as far as physical activity? What if somebody really ticks me off in traffic, man? You know, those are all the kinds of things that people with diabetes get impacted by because that psychosocial emotional health is also influences people's blood glucose levels. I'm going to just spend a minute or two talking about, again, the vision. We've mentioned a lot of this. You've heard about this all morning. We've, again, noted that diabetic retinopathy is a leading cause of new cases of blindness among adults, and that it really is a personal and societal problem, $5 million annually. These are data that we also want to share. You've had new data released. CDC also has data that we are responsible for on your behalf as the nation's surveillance system. So I wanted to, again, give you a sense of these data as well. This is a question I was asked by a reporter who was calling about this summit day before yesterday, I guess. And this is a concept that we were trying to convey to her, that you can see by the bars along here that as you move along for the number of people that are impacted by visual impairment who have self-reported diabetes, it has been on the rise. You can see a slight dip here now in 2010. But what happens, so this would give you the impression that these numbers are increasing. That is the absolute numbers. But look at the percentage and then the age-adjusted percentage. So here's percentage and age-adjusted. They're actually on the decline. Anybody want to speculate about this? Why are these seemingly counter, aren't they sort of giving you two very different impressions? Well, we're talking about absolute number of people. More and more people are developing diabetes. And as we have more people developing the disease, we have the likelihood of more people who would be candidates for vision loss. But we're actually improving in vision loss. Fewer people are having vision loss, except that the absolute number of people is becoming so large, we're overtaking the gains that we're making in those improvements. So what does that tell you? It means we have to not only be concerned about those who have diabetes, that we want to prevent them from having vision loss, but we need to outright prevent new cases of diabetes. If you're really going to start early in the continuum, let's prevent people from ever developing the disease. This gives you a sense of what it looks like in the future. You've seen data very similar to this, again, so I'll skip over that. Just wanted to share a little bit about the actual relationship of diabetes and what happens with those complications. You've heard a lot of this, so I don't want to spend much time, but certainly those issues that impact the retina and those that impact, again, cataract, glaucoma, macular edema. We've got a whole menu of options here for eye complications in diabetes. This really is impacted by a number of things in diabetes. Certainly high blood glucose levels. Those high circulating levels of sugar do damage those vessels in the eye, and we can talk about those, the mechanism of complication if anybody cares to talk about that. But it also does have to do with the duration of diabetes. I personally have lived with type 1 diabetes for 44 years, and those of us with type 1, we would likely not be able to avoid some change in our retina because of diabetes, particularly us old-timers who've had diabetes more than 30 years. It's really unheard of that we're complication-free, period. So it really does, again, matter how long you've had the disease. It matters the kind of care that you have gotten, and that's care that you have received and care that you have practiced, because it is a self-managed disease, but it doesn't mean you do it all on your own. It matters around what environment you're in. It matters the kind of support system you have from family and friends and society around you. All of those things have an impact. Gender, race, ethnicity also has an impact. A recent paper by our team did indicate men having a slightly higher rate, but you can see these bottom three can be impacted. Duration of diabetes you can't do much about. Gender, race, ethnicity, maybe gender you can alter, but pretty much none of those you can alter, but you can alter the bottom three. So we really do want to look to those things you have control over, that high blood sugar, high blood pressure, and cholesterol issues. So those are really the three that you can have significant control over. This is what I alluded to earlier. You know, so much of the time we get up and talk about the bad news. And honestly, there are people, we really do need to be accurate and clear what the story is. There is plenty of bad news in the diabetes world and in vision health world. But let's talk for a moment about the good news. We're doing some things right. Because you can see what's been happening to the complications in diabetes. We are having fewer cases of vision loss, amputation, end-stage renal, CVD hospitalizations, and total hospitalizations. But we're not where we need to be. So we can't kind of call it a day and say we're all done, we fixed this. But it should tell us, what are we doing and what are we doing right? What are we doing and what are we doing well? And that's why the public health work is so important, to examine what it is we're doing, how well we're doing it, and what should we be doing more of, what should we be doing differently, and what should we honestly stop doing because it's not effective. I put this really up here to make a major point, and don't strain your eyes to try to gather all this. Let me just point the high points out to you. What I really wanted to demonstrate again, and it's why our division took on the surveillance system, looking at it through the lens of health disparities, because there are still some real disparate issues, although the data presented earlier was fascinating, that it isn't always the high-risk ethnic groups that are experiencing some of these issues, but really it is hitting a lot of people, but some certainly more fervently than others. So you can certainly see that a non-Hispanic, Black, Mexican Americans harder hit. You move down here, those who have less than high school, education are also hard hit. Again, these social determinants of health that are not easy to deal with, are they? You know, I found as I moved into public health, I was trained as a basic researcher and as a clinician, and I moved into public health, and people do get kind of freaked out when you start talking about poverty and you start talking about issues that people feel like they can do zero about. But it is, I think, these kinds of issues that we really do have to be asking some questions about and addressing in our local communities. How do we access things? How do we pull together and help provide coverage and services for people when we may not be able to make them as available as quickly as we'd like through some of the policy opportunities that we have? So we have a ways to go. We are making some improvements in diabetes and in turn in vision health. There are things that still need to be done. We're not where we need to be. We're not across the finish line yet. But let's wrap up here by really just spending a little bit of time then on what do we do about it. So hopefully you've seen what the problem of diabetes is and vision impairment specific to diabetes. Things are improving in some ways, but we're having so many more people developing diabetes that unless we get a handle on what we refer to as primary prevention, while we continue to enhance secondary prevention, we are going to be seeing these scary projections that we have. And so really, I hope this will help us all get serious in our calls to action. In the case of preventing diabetic retinopathy, primary prevention is really an issue of, again, control of glycemia, hypertension, and lipids. Secondary would be people getting those surgical procedures or laser photocoagulation. And then you heard a wonderful presentation on rehabilitation services and how critical these services are for ongoing care. It's important that we address each of these areas. I remember when we began to work in diabetes prevention, so this is preventing type 2 diabetes, the most common form. And I have been making the assumption that you all know there's more than one form of diabetes, and maybe I shouldn't make that assumption. Type 1 is about 5 to 10% of the population. That's the form I have. It usually occurs when you're a child, although it can happen when you're an adult. Type 2 is the most common form of diabetes. 90 to 95% of cases are type 2. It used to be called adult onset. That's not true anymore. We're seeing it in our adolescents now. And then, of course, there's gestational diabetes happens when you're pregnant. Only form of diabetes that can be prevented is type 2, but we can control all forms of diabetes. But it does require a fair bit of effort and a fair bit of commitment. So I remember when we started to talk about preventing type 2 diabetes, people would say, we can't work on that. We've got our hands are full trying to manage diabetes. We couldn't possibly work on preventing. And the deal is, it's two sides of the same coin. If we don't prevent new cases, and we do know how to do this, we certainly know how to delay them. If we don't, we will overwhelm the system. Again, think about the comment I made. We're seeing an improvement in vision loss, but we will overtake those improvements as the number of people with diabetes continues to increase. So you must do both. We must do both. And that means then that you have to choose wisely in what you're doing. You can't run after every kind of program, every kind of thing, every kind of opportunity. You really do have to be asking some questions around what is effective and what's been shown to work. And one of the things that's certainly clearly needed in secondary prevention or in preventing vision loss is that people do have access to the eye care providers. Getting a vision check in diabetes is necessity. You cannot possibly know whether your vision is running into difficulties early on in the course of diabetic retinopathy. So there's some of these things that are absolutely foundational, and so this opportunity to have your vision checked. I was asked by one of the reporters too, well, why don't people get their vision checked then? What's so hard about that? You know, why don't people do it? What do y'all think? Why don't people do it? Okay, money's one. Insurance coverage. What's that? Okay, so they can get those. So yeah, why go get your retina dilated when I just think I need reading glasses? Has anybody ever had a dilated retinal exam? Okay, how fun is that? Really? Yeah, I mean, when my husband was alive, he had to say, can you come get me at the eye care? Now I sit there and wait for the little drops to take effect and your pupils to constrict again, and the sunglasses. And, you know, it's not like you sort of whip in and whip out. It does take time. And it does take effort. And so the more effort it takes, it's why we have to help people to understand and appreciate there is stuff you can do. Ignorance is not bliss. And then to really try to work with people to help them address their barriers. It's amazing how creative people can be when they are really asked to try to focus specifically on that and come up with some of those solutions that they really didn't think they could come up with. So it is understandable why maybe people aren't getting these kinds of exams that they necessarily need, but these cannot be barriers that are insurmountable because we know the payoff is so big. So let me close by saying what it is we're doing about this. You've heard some great examples of things that are being done clinically, and many of you in the room are clinicians, so you know that we certainly, again, need to be having the appropriate medical management of people with diabetes. That means being on the appropriate meds. It means taking those meds. It means getting information and support about how to manage your nutrition and your physical activity, those psychosocial supports and self-management training that you need to live with diabetes. Many of those things can actually be happening outside of the medical system as well, particularly self-management training these days. We now have community health workers and diabetes educators who work out in communities. And it also means people need access to those eye exams we talked about. They need to get access to the laser therapy and any other medical procedures that they need. But let's talk for a moment now about what we can do from public health perspective. What can you do that's going to help move the needle? You've heard about surveillance already. We need to be able to know who is most affected. I showed you that map early on, and you saw some of those parts of the country that are most hard hit. What do you think we should be doing with those kinds of map pictures, just looking at them and saying, oh my gosh, that's all blotchy and it's a whole lot of people? We really need to be saying, as members of our communities, what does it look like in my community? What does it look like where I have a sphere of influence, or my organization has a sphere of influence, or I'm a voter, or I'm a member of the student council or PTA? Think about where you are actively engaged in your community and begin to think about how to take vision health and those issues into your community. Think about those maps from that perspective. Then we need to know what interventions work. We've talked about a few of them. And I can certainly say that our team at CDC is working with a number of you in the room to help identify what interventions are even more important. And before I just touch on those quickly, I want to take you to this last step, implement. How do we do it? I heard comments earlier about we had grant funding and now it's gone. Yeah. We need to really be thinking about how do we sustain and how do we scale these interventions. I'd like you to imagine that you're walking up the stairway and we have got basic science at the bottom. We've got different kinds of research trials that we do in the real world. And then we move up into something where you have to deal with efficiency, distribution, and availability. And this is really where public health tries to do a lot of our work, is that we're trying to develop models that can be scalable and sustainable, but they can't be done by only these little grant dollars that we give out and that others give out. This is why the question earlier about policies and opportunities for things that are going to allow these efforts to be scaled and sustained. As a good example, I would encourage all of you to take a look at the National Diabetes Prevention Program on our website. And you can see that through that endeavor, we now have third-party payment. One of our partners is now a part of the CMS work that's going on that will look at reimbursing that intervention as a reimbursable service. And so I would encourage us all to be thinking about those, not just getting our programs out and running, but we have to start thinking about how do we scale them and sustain them. So here are just a few examples from our team at CDC. You've heard about these surveillance tools, and let me just say, Congress doesn't think these tools are sexy. So you heard questions about the BRFS, and you heard questions about what's happening with NHANES and the tests. We need people to speak up about these tests and these surveys. because they may not in and of themselves be that sexy sounding, but how are we going to be able to monitor the problem that we have, and how are we going to know that we're actually doing better and where we need to direct our resources? So I hope that you'll think about these as you're thinking about your agendas. Search for Diabetes in Youth for the first time ever. This is the largest study of diabetes in youth that our team leads with cooperation with NIH. Our vision team at CDC is working with those investigators on actually studying vision health in youth and being actually able for the first time to better understand what's happening to these kids who have diabetes. Health economics is another part of the work that we do. And then finally, this project called Insight. It's a network study on screening. And they're examining such things as screening for diabetic retinopathy in pharmacies. And again, we're using those retail pharmacies now as a place for screening people for diabetes and getting them immediately put into a prevention program. Why couldn't we be using those kinds of opportunities? But again, we need to do it not helter-skelter, not running off sort of, you know, willy-nilly. Bet your bippy, I'm going to say willy-nilly today. That you really do have to do this in a methodical, strategic way and not just, again, run off half-cocked. You really do have to think about how is this, some of this can be leveraged more appropriately locally, some of it needs to be leveraged through the state, and some certainly needs to be leveraged nationally. And then you heard earlier about the health departments. So let me close with our vision. Thought this was an appropriate way to end this. This is our vision at CDC for what we, on behalf of all of you and with all of you, are seeking to do in this country. Our vision is a world free of the devastation of diabetes, and part of that devastation is certainly vision impairment and vision loss. Thank you.